Thank you for this opportunity to discuss this very interesting topic of accelerated atherosclerosis in patients with rheumatic diseases. My name is Dr. Elaine Husni. I'm a rheumatologist at the Cleveland Clinic, and I am looking forward to highlighting the 2011 EULAR Annual Scientific Meeting abstracts. I'm going to begin with talking a little bit about atherosclerosis. As we know, the traditional model of atherosclerosis has really expanded over the past decade to include both an immuno and an inflammatory disease state. Over the next 15 minutes, I hope to highlight some of the recent research from the 2011 EULAR meeting as it relates to the impact of rheumatic diseases and cardiovascular risk. We're going to review recent advances in the area of cardiovascular risk assessment, including the subclinical measures of atherosclerosis and their usefulness as predictors for atherosclerosis. We will also assess the data on lipid profile modification, adipocytokines, as well as looking at HDL composition and their impact on patients with rheumatoid arthritis. Just as a brief overview, as we all know, there has been convincing data from epidemiologic studies indicating that rheumatoid arthritis is an independent risk factor for accelerated cardiovascular disease. And despite adjusting for the traditional cardiovascular risk factors such as obesity, male gender, smoking, this still holds true that rheumatoid arthritis is an independent risk factor. Thus, people have hypothesized that chronic inflammatory burden have been implicated in this initiation and progression of cardiovascular disease. However, the precise mechanism behind this is still unclear. So there has been growing studies and investigation trying to find this link between cardiovascular outcomes and rheumatoid arthritis. Our first abstract is going to be looking at just the comparison of cardiovascular risk factors between patients with RA and the general population. Many theories have included either the clustering of cardiovascular risk factors in that particular group versus a high-grade chronic inflammatory disease process as the driving force. So the objective of this abstract was to compare the prevalence of the classical cardiovascular risk factors in RA to the general population. They looked at a large outpatient rheumatology clinic compared to a sample in the general population from the same region in the Netherlands, and data were collected by direct measurements as well as analyzing by particular gender and age. The results of this abstract showed that when you're comparing 345 RA patients to the general population of over 4,500, that RA patients still found to have a higher prevalence of cardiovascular risk factors. They dug deeper into this and even reported that in patients that were women with RA, they were more likely to be overweight, obese, and diabetic, while men with RA were more likely to be smokers, hypertension, and have a low HDL profile. So despite this increasing attention to cardiovascular risk in RA patients, there continues to still be a higher prevalence of cardiovascular risk factors compared to the general population, and this was also specific with gender-specific parameters. Looking into the next group of abstracts, we wanted to have a sense of what would be considered useful predictors of atherosclerosis. So at what point can we try to find these risk factors earlier and beyond the traditional risk factors? We're looking at vascular outcomes, novel biomarkers, as well as calcium scoring. So in this first abstract, we looked at factors that might be predictive of cardiovascular risk beyond the traditional risk factors. There has been some literature looking at antibodies against phosphocholine, anti-PC, especially the IgM subclasses, that may serve as a marker for cardiovascular risk in RA patients. And these were examined for its predictive value for atherosclerosis. This study looked at 114 RA patients that were considered early RA patients, and they were assessed at baseline, 3, 12, 24, and 60 months. And these looked at certain parameters to look at its usefulness as predictors of atherosclerosis. And this looked at with an IMT as well as a presence of plaque. And as you can see here listed below, ApoA1 was a negative predictor with IMT, while the ratio of ApoB and ApoA1 ratio was a positive predictor of IMP. The other positive predictors of plaque presence, as you can see, are listed here. ApoB, ApoB-APO1A ratio, as well as CRP and having low anti-PC tertiles. While our traditional RA disease measures such as SED rate, DOS-28 tender, and swollen joint count fail to show any statistically significant association with these study outcomes. So turning to the next study, keeping in the same theme of useful predictors, this was a Russian study done on 112 RA patients over 5 years. This abstract examined carotid ultrasound, brachial artery reactivity, ABI calculated at study entry. All patients were followed prospectively until the outcome of interest, which is the first vascular event, which could be ischemic heart disease, the TIA, or cardiovascular mortality. And these results showed that there was an increase in IMT and the presence of plaque significantly predicted development of cardiovascular or cerebral vascular outcomes. So among the RA disease characteristics, such as erosions, extraarticular manifestations, smoker, family history of CAD, was associated with increased vascular events as well. And more interestingly, looking at the impaired brachial artery reactivity in response to nitroglycerin intake, there was an association significantly with vascular outcomes as well. Looking at the next slide, also continuing the theme of useful predictors, this study was looking at the ESCAPE cohort. This was a U.S. cohort looking at the evaluation of subclinical cardiovascular disease and predictors of events in RA patients. Although RA patients are known to have higher calcium scores and controls, the rate of this progression remains unknown and the objective of this abstract. This was a prospective cohort looking at 155 patients compared with 835 controls. And they found that 20 of the 73 RA patients who did not have coronary calcium at baseline did develop detectable coronary calcium during the follow-up visit. Overall, however, RA and non-RA patients did not really differ significantly in their rates of incident or progressive coronary artery calcification over the 2.5-year follow-up. We will now look at some abstracts looking at the effect of aggressive immunomodulatory therapy for RA patients and cardiovascular risk. This is another area of interest. So the next slide summarizes 2 studies, one by Sitko and the other by Fasenmyer. The first study looked at a small cohort of 39 patients on anti-TNF therapy and watched them for over 12 months duration. And they showed a decrease in inflammatory markers, increased lipid profile in total cholesterol, HDL, and triglyceride, and the overarthrogenic indices improved overall. Interestingly, there was a significant reduction in other markers such as fibrinogen, AT3, PT, and an increase in PTT levels in this study. In a little bit larger study by Fasenmyer, 155 patients with early RA, defined as less than 2 years, on some DMARDs as well as some biologic therapy led to favorable changes of the lipid profile and decrease in the CRP DAS28 after 12 months. These changes were appreciated at 6 months as well. So this is one of the first studies I thought this was interesting and that it showed some favorable changes early on. So if you look at this table here, the effect of the RA treatment on lipid profile, you see here the parameters on your left-hand side of CRP, DOS, total cholesterol, lipid panels. And you see at baseline, 6 months and 12 months, that you can detect changes as early as 6 months in the lipid profile in those patients that are treated. So in conclusion of these 2 studies, it looked as if RA patients that had anti-TNF therapy can really affect their cardiovascular risk. Whether or not we know this exact mechanism of how this happens, we're probably not sure, but this can either occur through modulation of inflammation or modification of the lipid coagulation pathways. We also noted that patients with early RA have favorable changes in the lipid profile after 6 and 12 months of treatment, and that ultimately may lower their cardiovascular risk over a lifetime. But further investigation is needed to evaluate the extent to which inflammatory, metabolic, and coagulation pathways are mutually dependent in this process. Now, looking at lipid-lowering therapy, so this has been an area of interest we're looking at in the general population when we're trying to treat high cholesterol or dyslipidemia. We are now prescribing lipid-lowering agents. So in this particular study, it looked at a pool analysis of 2 prospective and 1 primary prevention statin trial. Their objective was looking at high-intensity lipid lowering versus regular lipid lowering in patients with inflammatory arthritis. They looked at all patients with inflammatory arthritis, including rheumatoid arthritis, ankylosing spondylitis, as well as psoriatic arthritis, and had comparable lipid-lowering effects, and similarly reduced the risk of cardiovascular mortality and morbidity after treatment with statins compared to those with inflammatory arthritis that was not treated. There was a similar study done in Russia that looked at 50 RA patients randomized with and without atorvastatin therapy, a lipid-lowering agent. They were on stable DMARDs and compared with 20 healthy controls. Their outcome measure was looking at lipid parameters as well as flow-mediated dilatation were measured at baseline in 24 weeks. And they also confirmed findings that the atorvastatin group, the group that was on a lipid-lowering agent, combined with anti-inflammatory, significantly reduced total cholesterol, LDL, ApoB, compared to baseline. So looking at this table here, they tried to split up the inflammatory arthritis. So as you can see, there are rheumatoid arthritis, ankylosing spondylitis, as well as psoriatic arthritis compared to the group on your right-hand side that was non-inflammatory joint disease. And these results demonstrated that patients with inflammatory arthritis have comparable lipid-lowering effects and similar reduced risk of cardiovascular morbidity mortality after treatments with statins as compared with patients without inflammatory arthritis. And interestingly enough, if you hone your attention onto the AS group, the ankylosing spondylitis group, the intense lipid lowering with atorvastatin seemed to be most effective in this group, despite the lower atherogenic lipid profile at baseline in these patients. So now we'll turn our attention to one of the newer biologic agents, tocilizumab and lipids. It is known that in this particular drug that it's been associated with increased serum lipids. But we also know that in the general population that CRP and IL-6 are very important inflammatory cytokines, and they are implicated in the progression of atherosclerosis. So looking at tocilizumab, which is a IL-6 blockade, it has shown to rapidly reduce CRP. However, as I just told you at the beginning, tocilizumab has also been associated with increased lipid levels. And so what does that mean in our patients that are being treated with tocilizumab? So this study looked at the characterization of lipid and APO levels in a pooled analysis of all the phase 3 trials of tocilizumab in RA patients. Patients that were not on lipid-lowering agents were included. And the results show that all cholesterol levels increased in tocilizumab-treated group. And as known, disease activity measures were also much improved. And this provides some evidence that IL-6 is a key regulator of lipoprotein alterations in patients with RA. So looking at another study of tocilizumab, this was a much smaller study looking at 20 RA patients over 24 weeks that underwent tocilizumab treatment. They looked at monthly labs as well as IMT data at baseline and 6 months. Not surprisingly, CRP had decreased significantly in the tocilizumab group. The total cholesterol level had also increased significantly. And there was actually no change in the IMT, either in the group with or without statin therapy. So tocilizumab may not promote atherosclerosis in RA patients in the short term is what the authors concluded for this particular abstract in tocilizumab. So now we're going to turn our attention to adipocytokines. This has been a relatively new area looking at the adipose tissue. and looking that central obesity is metabolically active. So what does that mean? So that means that adipocytokines that live in the adipose tissue can actually secrete inflammatory mediators, which has been suggested to link the state of obesity to inflammation. And the objective of this abstract was to analyze the relationship with adipocytokines from the subcutaneous adipose tissue, which we'll call SAT, versus markers of endothelial function and systemic inflammation in RA. This abstract results showed that the subcutaneous adipose tissue, TNF-R2 and plasma CRP and plasma concentrations of MCP and PA1 metabolic cytokines is higher in RA patients than controls. The extracted subcutaneous adipose tissue, in particular PAI1, were higher in controls than patients. So there was no correlation between markers of endothelial function and measures of inflammatory mediators. The authors in this abstract concluded that inflammatory mediators that were from the subcutaneous adipose tissue are more closely associated with markers of subclinical atherosclerosis than the same inflammatory mediators analyzed in the plasma. And they conclude that adipose tissue-derived inflammation may lead to a very important increased risk of cardiovascular disease seen in RA patients. So changing our attention to HDL composition, this is a very interesting area of atheroprotective area. We all know that HDL is the good cholesterol and LDL is considered the bad cholesterol. However, sometimes the good cholesterol can turn into not such a helpful good cholesterol. And this is a concept behind looking at HDL composition rather than just HDL volume. So in chronic inflammation, it has been associated that lower HDL and changes actually in the HDL protein composition could occur and rendering it to be less anti-atherogenic, so less helpful as a good working HDL. In this small study, 50 patients on etanercept and 50 patients on adalimumab were studied. They were followed at 1 month and at 4 months, and changes at lipid and HDL composition through mass spec were assessed. And these results showed that in patients that responded versus patients that didn't respond, the responder patients had an HDL that was increased and a total cholesterol HDL ratio that was decreased. While in the non-responder patients, total cholesterol HDL ratio increased and ApoE decreased. So what does this all mean? So the authors concluded that in the preliminary analysis of just looking at HDL composition, there was some serial changes in 14 markers in patients that were responding to anti-TNF, indicating a putative improvement in the atheroprotective capacity of the HDL. So the HDL protein composition becomes less pro-inflammatory, and this could indicate that atheroprotective ability of HDL cholesterol may improve. My understanding is that these HDL assays are very tricky to do, and I think we will be hearing a lot more about these in our national meetings upcoming, really trying to analyze what does HDL composition have to do with risk as well as responding to treatment in our patients. So now we're going to look at biomarkers, looking at plasma biomarkers panel and the cardiovascular risks when patients are being treated for RA. We know now the mechanism of cardiovascular risk reduction with the anti-TNF seems like a plausible hypothesis, but the true mechanism, underlying mechanism that accounts for this is really unclear. So ongoing studies tried to look at the effect of biologic treatment on a cardiovascular biomarker panel. In this particular one, looking at cytokines, MMP, VEGF, high-sensitivity CRP, and troponin 1. They looked at both the effects of anti-TNF therapy versus T-cell co-stimulatory modulation on cardiovascular risk biomarker panel as well. This was an observational cohort looking at 60 patients. They were measured, their biomarkers were measured at baseline and at 3 months at follow-up. And if you look at this chart, I know it's a little overwhelming with all of these biomarkers on the left side. But interestingly, as expected, the DOS28 did have a significant difference in the treatment versus a non-treatment group. But we also noted that there were particular results that seem to be more reduced in both those groups. And that would be the VEGF, the IL-17F, the IL-6, the total MMP9, and the pro-MMP9. So the authors concluded that, as expected, the DOS28 and CRP were significantly reduced, but they also found in their battery of cardiovascular biomarker panel that there were also certain cytokines and biomarkers that did differ in the treated versus the untreated. And lastly, they also looked at the difference in drug effect. However, there was only one plasma biomarker that was different, and that was the STNFR2 that were different when we were looking between treatment groups of anti-TNF versus a co-stimulation molecule. So that sort of wraps up some of the newer highlights from the EULAR 2011. It's important to note that the EULAR recommendations, although coming out earlier, does exist for cardiovascular risk management. Here are 10 recommendations from this paper, and I have highlighted the first 4 just to remind us what we should be looking at regarding these diseases and cardiovascular risks. Most of this article was concentrated on rheumatoid arthritis, as that is the more commonly studied, but surely could be extrapolated to other inflammatory joint diseases. So RA should be regarded as a condition associated with higher risk. Adequate control of disease activity is necessary to lower this risk. And it is recommended that national guidelines will be used for cardiovascular risk assessment for patients with RA. And interestingly, just putting your attention to number 4, it looks like the risk score model should be adapted, meaning that a multiplication factor should be used when patients with RA meet 2 of the following 3 criteria: disease duration for more than 10 years, rheumatoid factor or CCP positivity, or presence of extra-articular manifestations. On the next slide, I decided to include 5 through 10, which are still important to note. But for time's sake, I just wanted to have the slide here so that you are aware, and we won't belabor and go over all 10 points, but this would be an article of interest for someone who wants more detailed study of this area. So in summary, it looks like it's critical to provide optimal control of cardiovascular risk factors in patients with inflammatory arthritis, just as we do in the general population. There needs to be some consensus on the ideal subclinical measure or predictor of cardiovascular disease, and I hope that I've shown you some useful predictors from this meeting. And further clinical trials would definitely benefit us in defining the impact of immunomodulator therapies and tight control of RA on cardiovascular outcomes. So I believe that RA serves as a unique model to study the impact of this chronic inflammatory burden on accelerated atherosclerosis. The potential of inflammatory modulations in rheumatoid arthritis may provide great insights to halting atherosclerosis in inflammatory arthritis as well as the general population. So I wanted to thank you for your attention, and I hope that this was a useful exercise in reviewing some of the latest abstracts presented at the EULAR 2011 meeting. I look forward to hopefully talking to you next year and giving you updates on the ACR as well as EULAR meetings to come. Thank you for your attention.